Pankaj Nand Chaudhary sir as the moderator, Dr. Dilip Bhalla, Dr. Neeru Aggarwal, Dr. Naresh Aggarwal, Dr. Gangwal and Dr. Meenakshi Jain on the chair, please.
So this is the last session before we close this meeting. So I think most of the things have been covered, and the one point I think I would like to highlight in the previous talk, that yes, we could start HL2 up to 20, but definitely they would have some glycemic effect even. Previously we thought that there was no glycemic effect, but renal safety would be there and glycemic effect would also be there. So it's not there that we should not write, HLD2 in the question. Okay. So I think there are some ceremonies going on, so we can have 2 minutes time so that they can.
My only request to the moderator is that I think it's been a long session. Most of the people are uremic, I think, by now. So let's keep it short.
Yeah, very short, sir, very short.
And concentrated nephrology.
So by moving from the hardcore nephrology to a nephrology of physician's perspective, right? So there may be some questions which would be in our minds and probably because of inertia that would not be answered. So I would take that question only, right? Because of physician's point of view. So Dr. Setu, I think we can, Dr. Ajay, we can have. So now moving on to nephrology to infections, right? I think the bread and butter of physicians are patients of infection. Okay, sometimes patients come with urinary tract infections and you want to treat it. So first question would go to Para. Dr. Para was sitting idle for some time, right? So how do you define? Suppose sometimes it has been written in the text that this patient having uncomplicated UTI and patient having complicated UTI. So how you define these terms so that we would be easy to us to treat those patients? So the definition of this terms like.
Okay. So I think we all know simple is simple and complex is complex. So simple UTI means somebody coming with just dysuria, increased frequency and a little suprapubic pain. Then you call it simple UTI. If patient is having severe fatigue, high fever, is having features of sepsis, going further with renal angle pain or pain in the costophrenic region, drop in the blood pressure, increasing heart rate. So the features of sepsis taking up would be a complicated UTI. So going further would mean, is the situation with complicated UTI more complicated would mean the both host factors and the agent factors. So host factors would be if somebody is diabetic, old age, immunocompromised, on certain drugs which make him immune compromised. So that's the situation that we need to decide when we say whether the UTI is, as we are saying, asymptomatic bacteriuria to a simple cystitis, then to complex UTI.
Right, I think Dr. Pala, you are absolutely right. I think in the last the annual conference was a quiz like, say if the patient comes in simple or uncommon UTI, which is the feature which is not present normally? So the answers were 4, like patients have dysuria, frequency of micturition, some suprapubic and fever. So they were the 4 things. So I think that's
right. Once you have fever, it is complicated UTI.
So in uncommon UTI, there should not be any fever. So if the patient come into you, कि सब बता रहा है आपको, सब problem आ रही है और fever नहीं है इसको, तो possibly this you are dealing with the patient of uncommon UTI and this can be managed in outpatient department as well. If the patient is having fever, then you have to actually screen for patient which would be complicated. I think this is very simply in the quiz actually, and most of the postgraduate students did not answer the rightly. So I think fever is there, so it means you are dealing somewhere in the complicated and definitely you have to. So Dr. Paras, the patient comes with UTI symptoms, so how would you treat? Definitely you would ask for patient to have the urine culture. And regarding the antibiotic duration, there is some very issues over. Some guidelines say yes, only 3 days of antibiotic would suffice. Some say that only 5 days of antibiotics would suffice. And sometimes we are actually, the physicians, give more 7 days, 10 days antibiotic. So patients of simple UTI, suppose patient coming with dysuria and some culture positivity like E. coli, female patient coming to you. So what would be your duration of antibiotics to those particular patients?
So it's like Simple UTI patient coming to you, that's why we need to know the whole profile of the patient. First, the patient is having simple UTI or complicated UTI. Then the host factors would also become important. In patient with simple UTI, obviously you will send the urine culture ideally, but you have a regimen to choose. So what they say is that you also need to define that the patient coming to you, what are the chances in which strata the patient lives or the zone the patient lives, chances of fluoroquinolone resistance, what are the chances of patient having a MDR bug. So how is it defined? In India, the fluoroquinolone resistance is now increasing, it's more than 10%. So most of the guidelines say that if the resistance is more than 10%, you have to at least be aware of that fact that if I am prescribing a quinolone, how much are my chances of failure? Same is, your patient is coming to you after already visiting another physician who has prescribed him some medicines in the past. So what they say is that you define what are the chances of a MDR bug in that patient. So how do we define the possibility of having an MDR bug? If somebody has received an antibiotic in the recent past, if somebody has been hospitalized, if somebody has been catheterized, some urological intervention has been done in the patient, or if somebody is staying in the nations where MDR bugs are more. So India is one of the nations where MDR bugs are more. So you have to actually see the profile of the patient. So by going this definition, India being the host nation for MDR bugs, we have to be really wary in choosing our patients. More so when patient is coming with frequent treatments for the UTI with your colleagues who are treating. So then your chances of taking up an antibiotic has to be accordingly to a category where your chances of success are more. So making that further simple, maybe it was first occurrence of UTI as a simple cystitis in a patient, you may still continue to choose a quinolone, knowing that the chances are 10% you would still not be able to treat. You can still treat him with Septran. You can treat him with a single shot of phosphomycin sachet only once, if it is a simple cystitis. If patient is having complicated UTI, then you have to define it further that if patient is having, again, if it is complicated UTI, you have to see again how many things are involved. If it is just fever without pyelonephritis, your duration of antibiotics would still be 5 to 7 days depending on the agent that you are choosing. If it is pyelonephritis, then your duration of antibiotics is going to be, if it is early pyelonephritis, it is going to be at least 14 days. If it is again with some chronicity, the duration of antibiotic would go to 2 to 3 weeks. If it is again severe, the duration of antibiotic in pyelonephritis would go 3 to 6 weeks also. If the patient has developed renal abscess, you would have the duration of antibiotic going to 4 to 6 weeks at least. Similarly, if patient is having prostatitis or prostatic abscess, your duration of antibiotics is going to change. In prostatitis, it is going to be at least 2 weeks. If it is prostatic abscess, it is going to be 4 weeks. Again, as the complexity of the situation arises, your cultures have to be very well sent at the first go so that you don't get trapped. Otherwise, it's all going to be empirical according to the available data in the area that you practice.
Right. So Dr. Bhalla, this patient comes to you in OPD, like simple cystitis, female. Yes, sir. So we'll have the audience question. This is just a few flow, then definitely we have the audience.
No, I don't think you don't have to give 2 drugs. Yes. So I think what is important, Dr. Paras has mentioned very nicely, it's a simple UTI, it's a cystitis, it's a complicated UTI is there. Now you have to realize where the infection is. Is it in the lower urinary tract or in the upper urinary tract? Lower urinary tract symptoms, you will have features of lower urinary tract symptoms, dysuria, pain, frequency. Cystitis, you will have suprapubic pain. If there is upper urinary tract infection, you will have fever along with some suprapubic dullness. Now that is when you will decide, you will investigate Ideally, what is to say that a good urine routine examination, if you can see WBC CAS, which we don't see nowadays, that would tell us that the infection is in the kidneys. That is, it's an upper urinary tract infection. Right? So that is what number one to tell you. The duration of treatment is important. Simple UTI, 1 dose to 3 to 1 dose to and the treatment can vary between 1 to 3 days. If it is a infection that is there, if you are having cystitis, you can go for 7 days. If the patient is having pyelonephritis, important if the patient is having fever with pyelonephritis, you must treat the patient with parenteral antibiotics. Parenteral antibiotics, no oral antibiotics. And the dictum is that you must give parenteral antibiotics until the patient is afebrile at least for 72 hours. If he is afebrile for 72 hours, that is the time you will switch the patient to oral antibiotics. Give for 14 days. And then go do a repeat culture, and then you decide what is to be done. Then other chronic conditions, I think abscesses and all, I think that can be, the abscesses and prostatitis, they become a different category altogether. So this is how, as nephrologists, we go. In addition, what is important is the hygiene that is there, very important. And one is you to must change the pH of the urine. If the patient is having E. coli, it is very important that you must make the urine acidic, as opposed to the all other drugs. So a common problem that we see that every patient who has dysuria, alcohol is given. That should not be given. We hope that it's symptomatically better. If the patient is having E. coli, make the urine acidic, just give him simple saline, vitamin C. In an acidic urine, E. coli does not grow. So give the patient saline, maybe you can give it for a month, and then treat with the appropriate antibiotic for the appropriate duration of time. So this is how we approach patients with UTI.
As you asked for the dual antibiotics, if it is complicated UTI with ESBL organisms and it's a risk category 2 or 3, you may have to give dual antibiotic in that situation, but not for the simple UTIs.
It's a simple question. Patient comes to you with simple UTI. You want to confirm with the urine culture, and you also want to prescribe medicine on day 1. Very right. How do you manage? If a patient, when you prescribe medicine, antibiotic, patient will start taking antibiotic in the same day, and you get the culture the next day.
So it is a simple, if a patient comes to you with UTI, what you do is that you tell him that you please give your urine for culture, adequately hydrate the patient and put him on a quinolone, right? Wait for the culture report to come after 3 days, and then change accordingly.
That is the problem. Patient will not get the sample done on the same day. Most of the lab refuse the samples on that day. They will say, get the fresh morning sample.
No, that's wrong. You have to take a midstream sample.
That's what I'm saying.
Yeah.
Even Dr. Lal patient, they refuse the patient. They said, come tomorrow morning.
I think we as physicians need to realize that this concept of morning sample was for ease of work, right, and managing the work hours. They used to fool people. Now it is point of care testing. We need to counsel patient that आज अभी sample देगा अभी मतलब अभी और sample देने के बाद ये antibiotic शुरू करेगा. That's very very important that we stress on that. But still there are situations. Then in those situations, Dr. Bhalla, do you advise them to keep the sample and start the antibiotic and give the sample next day?
What I do actually in this situation is, I tell the patient that if you have infection, it would be picked at any point of the day. So you can give the culture now also. So they are convinced that it is not necessary to give the morning sample. Then whatever local nearby nursing home or hospital is there, you send the patient there and let them give the sample there only. It will be taken away and put for culture.
So I think very important point that cultures can be given at any point of time, and in fact, patient usually comes because normally we do the evening clinics, right? And patient comes with symptoms of UTI, so we can't wait, So there you can give the sample, but problem that lab is functioning for 24 hours. That's more important because some labs are not functioning in the evening, right? Suppose the patient gets into max is 24-hour working, then you can have the sample. But if you get the sample at this culture won't go to the lab, then it would be suddenly could get some infections. So it's very important that culture the sample should be sent there and there only. Not you have to wait since morning. आपने culture रख लिया आपने urine आप सुबह भेज रहे हो को. I think that should not be done. Right. This is the practical problem with the patient. So this is a misconcept. Yeah.
You said them right, otherwise I'll come and set them right tomorrow morning. This is pure.
So that is where the physician has to be proactive.
Yes.
I
We have
think
to
that way
be
we are
proactive.
talking about being proactive. This is where you have to be proactive.
But Neeru, how you investigate those patients of complicated UTI, right? Suppose patient comes with this flank pain and fever and high counts, and patient have some urinary symptoms. So how you investigate those patients?
So urine routine and culture we have already discussed. So you need to take the complete history is very, very important. So if suppose it's a patient of structural malformation, polycystic kidney disease or some posterior urethral valves or something like this. So our patient is a neurogenic bladder case. So these things are usually diagnosed early and the history will give you this answer what type of infection it could be. So depending upon the history of stone disease or any such thing, you will initially do an ultrasound. If ultrasound suggests that there is some hydronephrosis is there in one or other kidney, then you, of course you would like to go for the CT scan of the patient. And hemogram and KFT are routinely done for all the patients. Urine culture, since patient if has complicated UTI, that means having high grade fever, so a blood culture should also be sent along with this.
So what you would advise me is contrast enhanced or non-contrast enhanced?
Normally for kidneys, non-contrast enhanced CT scan is good enough. It gives us sufficient information.
Sometimes you feel like because if you give contrast, the contrast has its own problem.
So, yes,
right?
if patient has acute pyelonephritis, yes, it can sometimes cause contrast
Because
associated
sometimes
nephropathy and
radiologists
it
say
can
that you have to
injure
do
the
a
kidney.
contrast enhanced just to look to promptly diagnose the case of pyelonephritis. But normally in regional stones, definitely we do the
So
non-contrast.
sometimes what happens is you can see emphysematous pyelonephritis. That is one of the most dreaded complications. Like Dr. Neeru mentioned, a simple non-contrast CT can be done immediately. You should not miss out these conditions. That's important.
Right. So moving from infection to very important pertinent, problem with the physicians are PPIs, right? So today we have a very talk on GERD and we are, having.
I have a question from Dr. Bhalla. So, since the context of contrast was going on, so we have a lot of patients which we want to do contrast CT scan, and for liver contrast CT scan, there is no point getting a non-contrast. The creatinine is around 0.9, 1.1, 1.3, 1.4, but the patient has good urine output. So how do we go? The radiologist always refuse.
Yeah, I think first of all, there is a myth about contrast nephropathy. What we were taught around 15, 20 years back that it is to be avoided, there is no contraindication for giving contrast. Now, I was lucky to do a debate in my parent institution where we discussed the pros and cons, contrast versus non-contrast. So what we found was that when we do a propensity scored analysis, that is when you compare two groups of patients, one given contrast and the other patient not given contrast, it was found that the patients having renal failure was more linked to the other factors rather than contrast. So in simple terms, contrast is not such a bugbear and it is not such a thing to be scared of. Number one. Number two is that the dye that we're using non-iodinated contrast across the board. So it is safe. Yes. Third thing is that adequate hydration is the only thing along with statins to be used to prevent contrast nephropathy. And the fourth thing, if you feel that the benefits are going to outweigh the ill effects of contrast, don't hold back contrast.
So any cutoff for?
No, we don't give any cutoffs. We don't give any cutoffs. If you feel that it is very important, even because we see this every day, we get consults. Yeah, no, if we see patients with pancreatitis, we get these consults every day from the cardiology department. We tell them, you please go ahead.
Okay.
If you feel it is life-saving, there is no contraindication to that. Please go ahead.
One more query regarding the infections. See, majority of cultures report that you get, azithromycin always there, and 90% it is sensitive. Now, do we give azithromycin in the infection?
Sir, if I have nothing else is available and the culture is from a good lab, if that is the only drug that is available, I will use it.
What is the expression
So, see, it is a macrolide antibiotic. Mainly, it causes hepatotoxicity. It is good. Can be used in patients with UTI. You can use it in patients with UTI. But having said that, it will not be a first-line drug. We will not use it.
I have a question on contrast only. Some labs say metformin बंद करो, फिर आप contrast work करेंगे. What is your take?
Metformin in general, is actually related to the GFR of the person. If patient has comorbid conditions, he is a diabetic, GFR is less than 30 ml per minute, and he has other comorbid, then it is likely to be some complication. But metformin, if GFR is good, is not supposed to be stopped if patient is taking it already for long
Dr.
time.
Dang, is it about lactic acidosis you're talking about?
I don't do stop it.
Yeah, we don't stop it, yeah.
I send a patient for a contrast study and they said ki metformin band karo.
No, I don't think there is any data saying that any drug of drug, bicarbonate to be stopped, there is no data which tells you.
One of the labs on that drug.
See, before the surgeries, yes, metformin is stopped, but before the investigation, it is usually not stopped.
Yeah, no,
So I think in contrast, I think hydration is more important than
the
anything else,
hydration
right?
and statins now,
Yeah.
right?
And statins have got some role in preventing the contrast nephropathy, and NAC is actually out probably because
So
a
yeah,
lot
so
of studies have come up.
see, a lot of things with the
Yeah.
dopamine, NAC, everything is out. Only thing now is that only statins and this. So we get this from our cardiology. We tell them you give them statins 40 milligrams, just hydrate them.
Yeah.
So that is all.
Yeah, so they-
Hydration is the best treatment for this.
So I think moving on to this PPIs, dilemma, right? So I think Dr. Naresh is here, and I think dyspepsia or GERD or whatever acidity, hyperacidity, is a national problem, right? Every patient is on some or other PPIs for months or years altogether. So I would see that if those patient comes to you, right, and patient is having some sort of kidney issue, some amount of proteinuria. So can it be attributable, or Neeru would be getting this answer because I framed this question for Dr. Neeru, that what is the ill effects of this PPI on kidney acid? Then I'll come to Dr. Naresh.
So as such, there are not many studies about it. And the only thing that has been, it is the circumstantial evidence that patients were being given PPIs and they were not on any medication, but the renal function deterioration was seen, some urinary sediment was seen. So it was observed that if it is given for 6 months or more, then PPI can cause acute kidney injury. If it is given for 4 years or more, then they cause this chronic interstitial nephritis. But as such, there are many more studies are required before coming to a conclusive data. But these are actually some small studies that these evidences have come.
I think the original of PPIs came as Dr. Arora. He was a professor in SGPGI. He went to US. He was working in Veterans Administration Hospital. So he has looked at almost 18,000 people who were in Veterans Administration, and he compared the incidence of CKD in patients given PPI versus not. And he found that the patients who were given PPI, the incidence of CKD was slightly elevated between 1 to 3%. So I agree with what Dr. Neeru said, that again the fear is more than what is there in the real world. So we should not hold back, and it's long-term effect that is.
But 1 to 3% is a low incidence,
So
right?
yeah, so long as the gastrointestinal is concerned, now the European and American companies want to put some warning on their leaflets that it can cause chronic kidney injury apart from osteoporosis and osteomalacia.
Right. Because
It's one of the most seen side effects of PPI on prolonged use. Don't know about acute kidney injury, but chronic kidney injury is known.
right. So I think
Hypomagnesemia, hypocalcemia, and
so a lot of electrolyte disbalance, osteopenia, osteoporosis, metabolic bone disease, and AKI, as you rightly said, has been reported. But actually, most of the patients say that if you stop PPIs, definitely I have some issues. So I cannot stop PPIs. So Dr. Naresh, just out of the box question.
So
that
now for last 1 month in India, what is happening? There is a search of
Vonoprazan.
a newer molecule. Let me get the opportunity to discuss that molecule is vonoprazan, and it is called potassium competitive acid inhibitor, PCAB. And it is proclaimed to be better than PPIs in terms of causing toxicity to various organs, particularly kidney, bone, and so-called dementia. But the matter of fact is that PCAB is in market for last 5 years only. It got FDA approved 4 years back. PPI have been used since 1991, and this warning came in 2007. So this was 17 years after the introduction of PPI in market that this was noticed. So we need to wait for PCAB, what it does or what it does not.
Right, I think today there was CME on GERD on this same vonoprazan upstairs also. So I think a lot of companies are coming up and they say that it is safe, it is effective, and only once a day, 10 gram or 20 gram dose. So I don't know whether what will happen, this would actually, another PPI, the future will tell us.
It's a new generation proton pump inhibitor.
Right. So Dr. Naresh, another very,
Sorry.
yeah. So Dr. Naresh, as you answered this question, the other question that comes to it that actually we wanted to cover because of the paucity of time, we could not cover. I think this HRS issue was actually we discussed Dr. Bhalla that the hepatitis syndrome sometimes comes with physicians also at times, right? Okay, what is this entity and how you diagnose? Just a few pearls about it because it's a very long topic, but just few pearls for physicians. That how you diagnose HRS, hepatorenal syndrome.
To talk in short about
Very short.
HRS is a one form of AKI in patients who have gross ascites, moderate to tense ascites with portal hypertension. So we don't diagnose HRS in patients who do not have portal hypertension. Particularly acute liver failure patients, if develop acute kidney injury, will not probably HRS. So HRS is some entity in which kidney structurally is normal. So AKI we have either pre-renal or acute tubular necrosis. In HRS, tubules are normal, glomerulus is normal, and this happens because of hemodynamic effects in the systemic circulation because of portal hypertension. And kidneys are absolutely normal. The definition is, by definition, is 50% increase in creatinine above the level of 1.5 milligram percent compared to the previous definitions in 2 weeks time. And previously it was called as HRS1, now it is called as HRS AKI. And HRS2, the so-called, which is a form of chronic kidney injury in patients of portal hypertension, is more or less similar to chronic kidney disease and does not have any different treatment than CKD, but except for the liver transplantation, either solely liver transplantation or combined with kidney transplantation.
So Dr. Bhalla, are you agree with this HRS?
Yeah,
AKI?
I agree with what he's saying. So now it is very important to know that HRS type 1, type 2, the whole classification is changed now. So HRS type 1 is HRS being called as HRS AKI. That means the renal dysfunction is there for 14 days. If the renal dysfunction continues from 14 days to 3 months, it is called HRS AKD. And if it goes more than 3 months, it is called HRS CKD. So the treatment, as Dr. Naresh has mentioned, is very clear-cut. When you have a patient with HRS type 1, you give them albumin, dietary infusions, you give them telepresence. HRS, AKD and CKD, these are the patients you go in for liver transplantation with concomitant renal transplantation depending on the GFR that you have. This is how you treat, you classify and treat.
And I want to emphasize here that these patients initially, because this is an extreme vasoconstrictions that lead to AKI basically, and their fraction excretion of sodium is usually less than 0.5 even. So these patients should be given enough amount of IV fluids in the form of saline rather than restricting fluids that they are not passing urine. We should restrict the fluids. They should be given fluids even if their albumin is normal. They should be given albumin for 3 days at least.
Some small comment. If we have diagnosed a patient of portal hypertension with HRS AKI, then we have to rule out pre-renal AKI by giving a fluid of 1 to 1.5 liters. If it does not respond, then we classify it as HRS AKI. Pre-renal patients will improve with infusion of 1.5 liters fluid. After that, we must restrict the fluid because patient is already overloaded with the fluid, and this happens because of reduced perfusion of the kidneys. And the treatment after that, when we have given 1.5 liters, is terlipressin and albumin. And terlipressin initially was given in bolus dose, now in the infusion form, and has a response of at least 70% in reversion of HRS AKI.
Correct.
I think for we as a physician, whenever we are having a patient with AKI, 3 things probably would be of immense importance. One is replenishing their volume, right? So rehydrate them either by taking the history of how much they have been having GA loss, how much is the poor intake that they have. So you need to rehydrate them first. Second is going to be taking care of the sepsis. So send the cultures, take care of whatsoever focus of infection is there. Third, in any given scenario, I think the intravascular volume is very important. So when we talk about any debilitated patient, the albumin comes into the play. whenever we talk of a CLD patient, the albumin comes into play. So you need to give them that intravascular volume by way of albumin. So I think for we physicians, it's always going to be those three things taking care of hydration, taking care of sepsis, and if albumin is too low, please take care of the albumin also.
So I think last two questions.
Then avoid those
Last two
nephrotoxic
questions.
substances.
Diuretic should be avoided, Lasix should be avoided in this.
So last two questions. Dr. Bhalla, as a physician, because the patient comes with stable CKD, creatinine hovering around 4.5, 5 or even 6 or 7, and patients are non-having uremic symptoms, patient is output is fine. Okay, so we refer to nephrologist, okay, the creatinine is 7, this patient would need dialysis. Right, so I would have the concept of, we can hold the patient for dialysis early versus late. So what is the take home for the physicians?
So I think the take home is that one is guidelines and the real world. Now the guidelines say that a patient, anybody with a GFR less than 15 ml. Now let's talk about GFR. Less than 15 ml is stage 5. That is the time when the patient needs renal replacement therapy. Let's forget the creatinines because now all the labs are giving us a GFR less than 15 ml. So basically, this is the time you advise the patient to go in for renal replacement therapy. If the patient wants it slightly earlier, we start preparing when the GFR around 20 ml, we start preparing them if they want to do that. But in the real world, what we do is that, at least what I do is we look at uremic gastropathy. If the patient is having nausea, vomiting, weight loss, lethargic, this is the patient who requires dialysis. Other than the urgent indications being, we all know, fluid overload, hyperkalemia, acidosis, pericarditis, that is that the patient will come to you in the emergency. But if the patient is coming to you in your clinic, GFR are less than 50 ml, compliant, educated person, wants to go in for full, that is the time you advise. 20 ml, if it's a long-term follow-up, 20 ml, you start preparing him. Or if the patient is having features of uremic gastropathy along with the other constitutional symptoms, that is the time as a nephrologist, I advise him to go in.
So uremic symptoms, go for albumin dialysis. No, uremic symptoms are not there, but eGFR is less than 20, start preparing, and if it's less than 15, stage 5 CKD, you have RT. Dr. Neeru, your comments on that, because it's a very important question for physicians.
They say if GFR is less than 30 ml per minute, at least introduce about renal replacement therapy to them. So whether it is an elderly patient who is above 70, at least introduce about that, because I am talking about the real world scenario, because if you tell them for dialysis immediately at 15 ml, then they will jump and they will start searching for other people who would suggest to not to go for dialysis. So RRT should be introduced, and if they are agreeing, then go for AV fistula formation. It should be done in all the patients, and it is going to mature, it's going to take time. They should be apprised about the need for dialysis and how it is done. If patient is young, then discuss about transplant and guide the patient as per their requirement.
So last question.
Again, some set of 10-15% would be those CIN types who are not having hyperkalemia issue, those who are not having fluid retention issue. So then they tolerate that urea up till 250 and they are still happy with that urea of 250, creatinine of 10 or 11, and still they are devoid of any hyperkalemia.
So Dr. Paras, just to bring about this confusion of CIN and CGN, that is why our national foundations are just giving you stages of CKD. The CIN, CGN, all that, when I was doing my DM, there was a lot of debate. Now nobody is talking about that. The stages of CKD, that is for you to decide how to go about for renal replacement.
No, what I am saying is that in the real world scenario, those who are with tubular disorders, they do not have issue of fluid retention, they do not have issue of hyperkalemia, so they continue to feature a little bit better than those who are fluid retainers.
So see, but the offset is that then they have bone disease, they have anemia.
That's true.
Yeah, so I'm not saying that.
In the real world scenario, they continue to get delayed.
Right. So last question, like I think Dr. Bhalla, you must be visiting ICUs, and all Dr. Paras was also there. Now the concept of this this ultrafiltration or the cytosorb or this heme adsorption. So what is the role? Because sometimes there's a very contradictory trials of that. It may be beneficial, it may not be beneficial. Because we do a lot of get of sepsis. Sometimes nephrologists say, okay, this patient needs some sort of heme ultrafiltration or some sort of cytosorb. So what is the current statement?
So first we talk about, so when you're talking about giving cytosorb, first of all you have to get the basic IL-6 levels done. Yeah. We had a lot of experience, we are doing it we learned from what we did in COVID times. So the normal IL-6 levels are around 8 nanograms, but if there's a more than 10% rise, that means around 80 to 100, that means this patient is having what we call a CRS or cytokine release syndrome. Now, what your heme adsorption and your absorbent therapies, including cytosorb, is doing is basically, they are just absorbing the cytokines that are there.
Endotoxins.
Endotoxins that are there. So you have various filters. You can have oxares, you have cytosorb, and things like that. So that is an indication. One is that you start early. One is you get an IL-6 levels. If there is a rise of more than 10 times, it is indicated. Now, the second is that start giving them early. You start within 24 hours, you will get the best response. There are studies from our institution, Max PPG, and follow-up studies in Vedanta. What our experience has shown in around 40 patients is that giving this has brought about only a hemodynamic stability in our patients, which may give us some time in increasing and improving the outcome.
Bridging therapy is called.
And also the experience has shown that in patients, in non-sepsis patients, especially in situations like dengue, in situations like pancreatitis, the response and the outcome is far better than in patients with sepsis. So this is what our real world experience is.
So any one or two short comments or questions from the house, then we can close the session. Dr. Gira wanted to ask you. You want to ask? Two short comments. Statins and
So all the studies have talked about atorvastatin, but we are okay with thing. First of all, as nephrologists, at least I am very scared of giving statins because they cause a lot of myopathy. So my patients will not tolerate that. But if a cardiologist is already giving them, then we don't stop them. And unless there is a situation when the patient is having active CAD or things like that, that is the situation we give them. And then you can choose between atorva and rosuvastatin.
Sir, myotoxicity is slightly more with rosuvastatin. So that's the reason it is not allowed. But only thing is atorvastatin, as we are seeing more patients who have high LDL levels and the direct risk factors for the major vascular events. So atorvastatin is being used. Fenofibrate is not used. If required, then ezetimibe can be added along with. So rosuvastatin, myotoxicity is more. That's the reason it is not used. And studies, as Dr. Bhalla has said, more on atorvastatin. So this is the, from our side, atorvastatin is the drug of choice.
For physicians, if there is anything renal involved, before calling a nephrologist, change the prescription from rosuva to atorva.
You can ask this question. Yeah.
Good evening, sir. Sir, if the patient is developing the AKI, the creatinine value is increasing and the EGFR is less than 15 and it's acute setting and the urine is passing, then we have to initiate the dialysis or we have to wait for decreasing. And if we have to wait, then how long we have to wait?
So I think that is a question that Dr. Pankaj had given me. So this is deciding between early and late dialysis. So yeah, acute setting. Not about chronic, acute setting. So there are two landmark trials. One is called the Akiki and the Elaine trial. They both looked at this acute. That means a drop in the urine output of more than 0.5 ml over 12 hours. Vis-a-vis a late, that is an acute indication of dialysis, which is acidosis, hyperkalemia, fluid overload. What they have found is that there is no difference in the outcome between acute and slightly delayed dialysis. So you have to individualize the patient and decide. The only difference that was found was in the Elaine trial, where they found that patients with polytrauma, there was some statistical difference in the outcome. So there is no difference between early and late dialysis and acute AKI setting. That is important, right?
Sir, one more thing. If a CKD patient is developing HRS AKI and usually we hold the diuretics, and if usually we hold the diuretics for the
the diuretics, what did you say?
Diuretic. Lasix we have to hold. But if the patient is passing the good amount of urine with the Lasix, then we have to continue our hold.
So one is that HRS AKI, one of the criteria, oliguria is one of the criteria.
Yes, yes.
Now the important thing is that you must realize that the albumin that is there in a patient with some hepatic problem or chronic liver disease, it is a dysfunctional albumin, right? So that is why it is not acting adequately. So that is why you have to tag your 20% albumin with Ditor or with Lasix for it to become effective. So one is that oliguria will be one of the symptoms. Secondly, your endogenous albumin will be ineffective, so you have to give them exogenous albumin along with tagging to bring out good amount of dialysis. That is where what Dr. Naresh was mentioning, that adequate hydration and give good amount of albumin to these patients. At least they say 60 grams per day, but we are not going more than say 30 grams.
Yeah,
or 40
it's 40 to 60 grams. One bottle contains 20 grams.
So I think I thank.
One second, his answer. If you are in doubt whether patient has HRS AKI or it is AKI other than HRS, go for the fractional excretion of sodium. If it is more than 1, it means it is ATN and you can treat different manner. If it is less than 1, it means it is HRS AKI. Although later, in the later part, all HRS AKI converted to ATN.
And of late now the NGAL, some substance in the urine, that is a very good substance coming
So
up
these are
nowadays.
the
that is
biomarkers, they
new.
are the biomarkers of
Yes,
AKI.
yes,
Yeah, they
yes.
can be used, but I
Yeah.
think more of clinical criteria has been used.
Yeah, upcoming.
So I think we thank all the panelists for an excellent show. I think we have covered, I think most of the questions that have not been answered during this thing, and have deliberately, did not discuss GLP-1 and HA2 that was discussed previously. So with this, I thank everybody who are here, still here, right? And I would hand over to our dynamic secretary, Dr. Tushar, to continue and to felicitate our chairpersons and panelists.
I would request Dr. Naresh Dang sir to please felicitate our faculty. With this, I would like to conclude today's academic feast. First and foremost, I would like to express my sincere gratitude to our esteemed speakers. Your insightful presentation and in-depth discussion have been cornerstone of this conference. Thanks to our sponsors and partners. I would also like to thank my MIDCON organizing committee and executive committee members for your hard work, dedication and meticulous planning. Finally, thank you all the delegates and the participants for your active involvement and enthusiasm in the conference. Thank you once again.
All the people who are actually involved in this would come, and we had the group photograph. Dr. Vijay Rodat, the chairman scientific committee. Dr. Anirudh Lochan is actually finally here. So I think Dr. Ajay, our vice.
And sincere congratulations to entire EDPA, the organizers, Pankaj, Ajay, and all the eminent nephrologists around the ring. Dr. Bhalla, please come on the stage.